Hey guys, welcome back. It's Dr. Radic, Dr. Rad, and I am here today to talk to you about having a bad hair day. No, I'm kidding. You guys are going to check these videos out because it's just me at home in front of a microphone just talking to myself. But I hope you guys are enjoying it. Today I'm going to talk about weight loss surgery and which one is right for you. I don't know. This is such a unique conversation. I don't think that anything really prepares you for this talk with your patients. And I don't know. I wish we did a better job of that in residencies and fellowships. In fact, I'll be honest with you. I don't think we do a good job of it at all as far as physicians go. I mean, our practice, I don't know if you guys know this, but most of our practices as physicians are just watching other physicians. And none of us had great formal training by any stretch of the imagination. You know, when you go in to tell somebody they have a terminal disease like cancer or something, and it takes the emotional toll on the physician. I know it's nowhere near what it's putting on the family and the patient, but you share in that, and then you do it many times in a day, in a week, in a month, in a year, and over your career. You know, the times that you have to walk out and say, I'm so sorry your loved one didn't make it. I mean, these things, unless you're a robot, these things take their toll on you. And if you take that and you kind of roll it over into, how about tough conversations like you're ready to lose your kidney? How about conversations like, hey, listen, we may have to remove your arm, because you were in a car accident and it's going to be lifeless. These kind of conversations. And then you can even roll it into weight loss surgery conversations. Things like, hey, why are you here? And what do you want? And in theory, what is it we're after and what's going to get you there? And what are you experiencing in your life now that could inhibit you from having one procedure or the other, or maybe you're experiencing things that would kind of promote you getting one over the other. And so let's just kind of go down that avenue. I'm going to take you through kind of a conversation that I have with my patients, and we'll go from there. So when someone walks into my office and we're here to discuss weight loss surgery, I can tell you, and I think the majority of my patients will tell you, the first question I ask them is, what are you doing here? And I know that sounds like the dumbest question ever. But we're kind of taught, at least taught us a couple of things, to ask open-ended questions. And what that means is just kind of open the door for some conversation. So not a point-blank fact question like, how old are you? I'm 17. That's it. That's all you're going to get. But if you ask a question like, what are you doing here? And funny enough, I mean, hopefully my patients know that I know what they're doing there. I've looked at the chart. We've talked. I've kind of seen their name on the chart, and I've kind of done my preemptive strike. But when you come in the room and you say, what are you doing here? And they kind of look at you, and most of them get a little grin on their face. They're like, I am here because, whatever. I need to lose some weight. I need this. I need that. And usually it's kind of a one-liner, kind of thing. And again, that is absolutely fine. Most of them are here, I'm here to lose some weight. I want to be healthier. And then you have to fire right back with another open-ended question, which is something like, well, what does that mean? I don't know what that means. What does it mean to be healthier? And then they end up, kind of saying something to the effect of, I want my blood pressure to be better. I want to be able to, kind of chase my kids around. I want, and then you're like, yeah, that's it. What else? And you just keep saying, what else? And eventually, within just the first 5 minutes, you have gotten the patient to really reflect on a lot of things. And what you're reflecting on is, what is it you're really doing in my house, right? And what you're doing in my house, meaning What do you want? There's no way you just want to lose weight. That can certainly be a large part of it, right? But what is losing weight going to get you? Like, is it worth having surgery? Is it worth, all the things that go with that? And so then you're asking the question, okay, so what does losing weight mean? Does it mean you're going to get off your blood pressure medication? Does it mean you're going to not have to take your cholesterol medication anymore? Does it mean you're going to be able to keep up with your kids at Disney? Right? Does it mean you're going to be able to, bend over and tie your shoes? You not have to wear slip-ons anymore? Does it mean that you're going to fit into that little dress? Right? Does it mean that you're not going to feel older than you should? Does it mean you're going to get rid of that stupid sleep apnea mask? Does it mean you're going to decrease your chances of a heart attack and you're going to certainly live longer? Does it mean you're going to have an 8-fold decrease in your cancer risk? Does it mean that you're going to feel better about yourself when you look in the mirror? What is it? What does it mean? And I literally will tell my patients, okay, we've started a list, but I want you to go home and every little thing you think about, everything, I want you to write it down, everything. So when you start the conversation of which weight loss surgery is right for you, you have to start with the question, what are you doing here? What are you going to walk into that surgeon's office and ask them to operate on you for? What is this for? And it's okay. Some of those may feel superficial. Some of you may not have one iota of medical problems, right? And that's because you're young, right? And the weight hasn't gotten you yet. But it will. Eventually, you will develop the medical problems associated with obesity. So I think that that's a great place to start. And then once you answer the question of why you're there, like, what are you doing here? Then I think you can start asking the question of, okay, well, it's like saying, I need to get to Tampa, and I live over here in, Vero Beach. How am I going to get there? Right? Then you can say, well, do you want to take the Prowler, or do you want to take the Mercedes? Would you like to take the Ferrari today? How about the helicopter or the G6? Right? There's a million ways to get to Tampa. How are we going to get you there? And then, believe it or not, there's the trick question is, well, if all of those things are going to get you to Tampa, what's the easiest? What's the most efficient? And those are all good questions. Okay, so let's back down. Let's knock out. Let's just talk about the top two. The top two surgeries performed for weight loss, right? We can briefly touch on the duodenal switch, which will be a number 3. That's fine. I will not talk about bands because I do not do them anymore. I think it's wrong to do them for the most part. There are probably a certain subset of patients who do very, very, very well with a band. I just think it's so rare and that the complication rates some point down the road are too risky. And it ruins really good tissue for a really great native or first surgery for a bypass or a sleeve, which are much better options than a band. So we're not going to touch on that. Okay, so let's talk about the sleeve. All right, so the sleeve gastrectomy has become exceptionally popular. It's fairly easy to do. I'm hoping most surgeons can certainly finish it in under an hour. I think the shortest I've ever done one is 27 minutes skin to skin. The longest was probably 3 hours and 27 minutes skin to skin. So it just kind of depends on what you got to do while you're in there. Usually you have some pretty significant nausea in the first 24 hours or so, but after that it really curbs off pretty quickly, and then you do really, really well. The numbers are somewhere between 65 and 70% of your excess weight loss at the first year. The problems are weight regain. Some great 10-year studies came out showing anywhere over 30%, 30 to 35% weight regain over 10 years. Now, hey, let's think about that. If you lose 100 pounds and you gain back, 30 of it, is that the end of the world? That's a whole heck of a lot better than, any old regular diet. I can tell you that. So, you're still doing great. You're still doing great. So it's a wonderful surgery. All right. Well, why would one choose the sleeve over, let's say, a bypass? Well, okay. So you have a 70 to 75% chance of getting rid of your diabetes. You have upwards of a 90% chance of getting rid of your sleep apnea. You have upwards of an 80 to 90% getting rid of your cholesterol issues. You're certainly going to lose plenty of weight, so your joints are going to get better. Your fatty liver is going to get better. Your blood pressure has this 65 to 75% chance of getting better. There you go. Those are great numbers that you'll never reach with medications alone, right? And certainly with dieting alone. What are things that would hold you back from a sleeve? And I would tell you that number one, at least in my book, is severe reflux. If you have reflux that is recalcitrant, or it is resistant to medication, it is a really tough road to hoe to get a sleeve, because sleeves typically make your reflux worse. I think majority of patients would tell you that. Typically, though, if you don't have reflux and you do get it, a little purple pill or something like that's going to fix it. If you have some reflux but it's well controlled on medication, then again, that doesn't stop me from doing a sleeve, because I'm assuming that you're going to stay controlled on your medication, and as you lose weight, that reflux will get certainly better. Again, you also have to know, and here's a kind of a nice sideliner. If you have severe reflux, you may have it for a reason, like a hiatal hernia or something like that, or an element of gastroparesis. So remember that, and of course you can fix the hiatal hernia while you're in there. And the hiatal hernias are a whole nother talk, so we'll knock that out at another point. But reflux is certainly an inhibitor, right? So if you have bad reflux and it's not well controlled, or you're the one who's like, dude, I'm swallowing a bottle of Tums on top of my Protonics, then I would theoretically stand clear of that. All right, so that's one reason not to do a sleeve. Sleeves also, in my opinion, need more discipline, right? We talked in one of our talks, you should go back and listen to it, is the history of weight loss surgery, and we talked about two big categories, right? One being restriction, which is portion control, right? And that's what a sleeve does, right? We're going to trim off about 85% of your stomach, so you are portion controlled. You're going to take 4 to 6 bites, and you're going to be full. You're going to be like, yeah, I'm done. Bypasses, obviously, we'll talk about in a minute, but they take advantage of two ways, right? Restriction, portion control, and malabsorption, right? Sleeves don't have malabsorption, so that's a good thing. One of the things, since you're not malabsorbing, if you have an element of iron deficiency, or if you have a low protein or albumin to start with, sleeves are probably certainly safer than a bypass at that point. That's something to consider. It's not the end-all be-all, but that's something to consider. But what I mean by the discipline is that, portion control is an interesting concept. I can give you a tool. I can give you a sleeve, and that sleeve is going to make it so that you eat 4 to 6 bites and you're full, right? Okay, so great. Here's the problem, though. I didn't say you couldn't have 1 or 2 bites every 20 or 30 minutes, right? And if you did that, you could absolutely take in 6,000 calories a day, regain all your weight back, no problem. So that leads us to Radke's rules, which is going to be a whole nother talk, but that is a simple way to fix these problems, and I'll certainly tell you guys all about Radke's rules, and I'll just do a whole talk on it. In my opinion, it's good for weight loss for people, and it's good for the not weight loss surgery people. It's actually exactly how I try to live my life. So I try and be the operative word. Nobody is perfect, I can guarantee you that. All right, so those are my kind of holdbacks from a sleeve gastrectomy standpoint. Now let's switch roles and go to a gastric bypass. So when I'm talking to my patients about a gastric bypass, I happen to love the gastric bypass. There is some bias there, right? I think it's a great surgery if done correctly. Again, it can be done in under an hour, maybe an hour and 15 minutes on average. It is a matter of can you what are the things holding you back from a bypass? Well, okay, one, if you are extremely obese, like very, very high BMI, you can absolutely, it could be a very tough surgery to do. This is not for the weak. Gastric bypass is a tough surgery. There's 2 anastomoses to do, one with the small bowel to the stomach and one with small bowel to small bowel. You got to move small bowel all the way up to the high end of the stomach. The liver can absolutely be in your way. I mean, this is not an easy surgery. Neither is the sleeve for that matter, but I think it's a little easier than a bypass. Having said that, bypasses are the greatest anti-reflux operation known to man, as far as I know. It has about a 92.5% chance of fixing or curing your reflux, which is awesome, right? I mean, the Nissen fundoplication, which is second place, is the best, surgery just specifically for reflux, and it's about 85%. So, I mean, the bypass is the best. There's no question about it, for good reason, right? So if you have severe reflux and it's not, your pill ain't getting the job done, boy, you get a twofer with a bypass, right? You get to lose all this weight and get much healthier, and you get your reflux taken care of. I mean, it's amazing. I'll walk into people's rooms the next day and I'll be like, hey, how's your reflux? They're going to be like, what reflux? Like, it's amazing. Okay, so that's a real good reason to have a bypass. And others are that the numbers are a little bit better, right? I always tell people they're 10 to 15% better in every category. So they're 10 to 15% better in your diabetes, cholesterol, hypertension, sleep apnea. I mean, these things, they're just 10 to 15, even weight loss, right? We expect 80% excess weight loss at 1 year. One of the things I love about a bypass is that it keeps the weight off. I mean, we've done long-term studies where people regain on average 10% of their weight at 10 years and 20% of their weight at 20 years. I mean, so that's phenomenal. You lose 100 pounds, you want to gain 10 back in 10 years and 20 back in 20 years, you're doing great. Right? The problem is everybody knows someone who gained all their weight back, right? And you can do it. It's a portion thing, right? You can find yourself eating all day long. Now, having said that, there are a couple of things that would hold you back, right? One is, we already talked about being a very high BMI can be tough surgery. That might be one of those situations where you do a sleeve first and hopefully you crush it and never need anything further. But if you lose 100 pounds, but you started off at 400, well, then we can turn around and do a bypass and you'll lose another 100, right? And that's the best part. Other things, iron deficiency anemia is an issue, right? Because you malabsorb iron significantly after a bypass. And we tell everybody after all weight loss surgeries, you have to know this. There's absolute must, sleeve or bypass. You have to take your vitamins every single day. You have to take an iron and you have to take calcium. You have to. I mean, some of the top diseases facing women every single day are osteoporosis, which is iron deficiency and weak bones, and iron deficiency anemia, right? And so then we're going to make it worse with a bypass because we're going to malabsorb calcium and iron, right? So you have to take these things. If you take them and your surgeon doesn't bypass like huge amount of bowel, then you're going to be just fine. You're going to be just fine. But if you're already starting off with significant anemia, iron deficiency anemia, of unknown origin or unknown cause, bypass is something you really need to consider or consider not doing, because it will cause worse iron deficiency anemia. Now, you could do iron infusions, once every few weeks but insurance companies got to pay for that. They get expensive. Some people just have genetically low albumin. That is something to think about. Again, it's not a gain, it's an absolute no, but you want to make sure that they are on top of their game with respect to getting their protein in afterwards. Other things that you just got to be mindful of with a bypass is that bypasses are a little more prone to getting ulcers after surgery in their new little stomachs. But why would you get an ulcer? A huge majority of people don't. I think the last number I looked at was like 14% over their lifetimes can get an ulcer. But you know what? If you're taking a bunch of NSAIDs, the ibuprofens and Motrins and Excedrins and Advils, stuff like that, if you're taking a bunch of those, you can get an ulcer anyway, whether you have a regular stomach or a bypass stomach or a sleeve stomach for that matter. But you're just a little bit more prone if you've had a gastric bypass. So from that standpoint, I would be cautious. If you are someone who just has horrible joint problems and you have to take, a bunch of ibuprofens or things of that nature every single day, or you just don't function. Then you have to be careful with the bypass. And then furthermore, I would tell you that with respect to potentially if you're a smoker, smokers have a tendency to get more ulcers. So again, if you can't quit smoking, then I would be careful with the bypass as well. But I gotta be honest with you, every single one of my patients have to quit smoking before surgery. And as far as I'm concerned, they should never, ever, ever go back, right? It's so bad for you. We could talk about that another time, but I know it's tough. I'm not even remotely saying it's not tough, but my God, of all the things you should quit in your life, that's certainly one of them. All right, so those are kind of my kind of tags as to why one would have one surgery over the other. I just because the bypass may be 10 to 15% better doesn't mean you should always just jump to the bypass, right? Either, like we said, we're going to Tampa. Do you want to take the Mercedes AMG or do you want to take the Ferrari? Well, they'll both get you to Tampa and they're both awesome cars, right? So it just depends on your goals. Again, it goes back to the question. What are you doing here? And what do you want, right? These are super good questions. So consider those, and please ask lots of questions and give me some ideas for talks you'd like to hear in the future. Hope you're doing awesome, and have a great day.